So let's get started. Good morning, good afternoon, good evening, wherever you are, and welcome to this GNN webinar hosted by WHO with the support from TechNet 21. We'd be happy to know who's with us today, so you can already introduce yourselves in the chat box and tell us your name, where you're from. You can also use the chat box if you have any technical issue, like a problem with sound. So please let me know and I'll do my best to help you. If you have any question during the presentation, please use the Q&A box. It's available at the bottom of your Zoom window. You can ask your questions at absolutely any time, and the panelists will answer them after the session, during the Q&A session, after the presentation. Finally, this session is recorded. We'll share with you the links to the video as well as the slides by email. I hope you'll enjoy this session, and I'll give the floor to Mario. Mario, the floor is yours. Thank you.
Thank you very much, and it's great to see you all again. As you know, NITAGs roles are really important and getting more important each day. So we have two interesting topics of how we can strengthen the NITAGs. We want to thank everybody that gave their responses for the surveys that are going to be presented today. And with no further ado, I'm gonna. I don't have a way to present the first speaker, so maybe Louise, you can present.
Yes, it's me present. It's Kamel and I on the survey for survey in mix, and I'll share the slides. And if I can find them. Yes. And over to Kamel.
Thank you very much, Louise. Thanks, Mario. I'm very glad to be here again with the colleagues from GNN. I'm Dr. Kamel Senoussi. I'm the director of ADVAC at the University of Geneva and also the director of Development Catalysts. Today, we're going to present with Louise the results of a survey that has been conducted recently on NITAGs in middle-income countries. And we're going to share the objectives, the results, and some summary of the results before opening for a discussion. So next slide. So the context of this survey is the fact that many countries, I mean, most of the countries have established NITAGs based on the data that are reported by the countries in the joint reporting form every year. So while most of the countries have established NITAGs, we see that NITAGs are reporting getting support from Gavi when they are Gavi eligible. And we also see that the high-income countries are supported by their own Ministry of Health in terms of finance and technical support. However, we also hear a lot from middle-income countries, NITAGs, that they are challenged in the activities around the NITAGs, and they have some specific needs and challenges. And the idea of this survey was to try to identify the successes, the issues and challenges around the decision-making in those mixed NITAGs. So the objective was really to identify the structural and operational factors that are enable the NITAGs in middle-income countries to generate timely evidence-based recommendation, to explore the issues and challenges, to identify the unmet needs for training, and also other kind of support that NITAGs would need, and also to understand better the integration of NITAGs activities in middle-income countries within the overall policy-making processes and decision-making. So we did two things. We did an online survey for mixed stakeholders, which included NITAGs chairs, members, secretariat, and also other relevant stakeholders at the Ministry of Health. We also did some in-depth country interviews, mostly focusing on the chairs of NITAGs and the EPI manager, the immunization director, to try to understand the context using some very specific examples of recent NITAG decisions, recommendations for new vaccine introduction. So I'll present now the the results in terms of participation. So the online survey was developed and disseminated in April, and we shared it to 68 middle-income countries stakeholders, and that was done mostly through WHO regional offices colleagues and from the GNN, I mean directly from the GNN. So we reach out all those countries, and we got around 180 responses. We excluded 36 responded because first, I mean, most of them, they didn't really fill the form. They just responded to the first page. One country was not identified. Some countries were not mixed, and some participants responded several times to the same questionnaire. So we excluded that. Next slide. And what we got was at the end 148 responses, representing 56 mix. So you see that's quite large in terms of mix. We got a range from 1 to 10 responses per country because we sent the questionnaire to several people in the countries, and we asked them also to share internally with NITAGs and Ministry of Health colleagues. So we got those 148 responses, and you can see that we got more representation from some of the regions. We got, for example, a very high level of response in the Eastern Mediterranean region, and in some other regions we have less response. But you can see in the first column the number of countries with at least one response, and you can see that the percentage among the total number of mix in that region. So you see that the response rates varies from 40 to 80 to 90, but you can see that most of the time, except for the European region, we got a lot of a very good response rate, and you have the map on the right with the countries. Next slide. So of those 56 countries, 35 were members of the GNN, which is a good result, which shows that the GNN covers well the mixed countries. Next slide. And in those 56 countries, we got 27% countries that were GAVI eligible, 25 from formally eligible countries, and 48 from countries where that were never eligible for GAVI support. So you can see here the distribution by region using WHO regions, and you can see that if, of course, in Africa we have more overall number of GAVI eligible countries, which explains the higher number of responded from those GAVI eligible countries. You can see that in other regions we have a lot of former GAVI eligible countries, and in some specific regions even more countries that were never eligible. So that's a very good distribution. I think the distribution shows that the sample was quite representative. So next slide. Regarding the respondent themselves, among the 148 respondents, you can see that we have a big majority of NITAG members, NITAG chairs, NITAG non-core member, but also NITAG secretariat. And we got around 8% of respondents that were immunization EPI manager or director of immunization at the Ministry of Health. Next slide.
Yeah, and I think it's
yes, to you, Louise.
Yes, my turn now. So in terms of the questions, so the first questions that we asked in the survey was regarding the role of the NITAG, and the replies we got are consistent with the NITAG's mandate, meaning that the NITAGs in middle-income countries are mainly supporting new vaccine introduction, providing technical advice and support to the MOH, and developing evidence-based recommendations. So this is consistent with what we advocate as the core work, the bulk of the work of the NITAG. And they also noted that to fulfill this core mandate, the main challenges revolve around funding to support NITAG meeting logistics, but also insufficient resources for the Secretariat, and then moreover, having the capacity to gather and to assess evidence. And we'll come back to that a bit later. Most countries reported having a secretariat, which is reassuring, and most of the time the secretariat is hosted by the MOH the immunization program in 81% of the response. However, the respondents rated the quality of the collection, synthesis, and data analysis as the weakest compared to managing meeting logistics, drafting meeting minutes, and dissemination of recommendations. And what we want to flag here is really that we don't want the Secretariat to be solely service provider for organizing meetings, but we really want to have a dedicated technical secretariat for the NITAGs. And I think more efforts should be put on guaranteeing to have these technical competencies within the NITAG secretariat. So among the challenges listed for the Secretariat, it comes as no surprise, but the capacity and number of staff is the first one, followed by funding, and then further down is the technical expertise. 74% of the respondents reported that the composition adequately meets the needs of the NITAG. This is really the bright sides. Among the common gaps reported for the expertise to be added would be around social science, health economists, epidemiology and clinical trial experts. But overall, the composition of the NITAG is reflective of the diversity of members that WHO encourages and as included as a functionality criteria in the joint reporting form. For the decision-making process, among the challenges listed by the respondents, comes first is the lack of national and regional evidence, followed by the lack of access to available evidence. And then again, echoing the challenges of the Secretariat and the core challenges listed in the slides before, is the insufficient time to gather and to evaluate the evidence. Then there were a few more challenges listed, but I think this summarizes well the top challenges that NITAG in middle-income countries are facing. Most respondents, this is quite reassuring, most respondents believe that the MOH has a comprehensive knowledge of the NITAG's role, and they also believe that the NITAG has a comprehensive knowledge of the government immunization priorities. And consequently, the NITAG has also been in 67% of the countries responding. The NITAG has been involved in the strategic planning process or the so-called national immunization strategy. And this is something that we are really trying to encourage for all NITAGs in all income groups, is really to have this link between the planning process and the country strategy, so that the NIS will then inform the NITAG work plan. So I think this is something critical, and it's really encouraging to see that it is already the case for 67% of the respondents in middle-income countries. However, where we need to do more support and effort is only 33% of countries responding said that the NITAG has formal linkages with other advisory bodies, while 42% reported no formal linkages. And you see that you also have 25% who don't know if there are formal or informal linkages. This could be explained by the core members who are not necessarily well informed of how the NITAG is being integrated into the local immunization environment. And I think this comes again back to the Secretariat to really orient the new NITAG members when they are being appointed. Only 35% of the countries responded that that decisions without an NITAG recommendations were made. And what is reassuring is that when decisions were taken without the advice of the NITAG, it was mostly, or at least for half of these countries, it was during the COVID period. And we know that it was quite a unique situation where dedicated COVID-19 committee were being set up, and sometimes the timeline or the speed with which the NITAGs were expected to make recommendations could not be met, and the decisions taken without a NITAG recommendation. So I think this is something that we could track in the future, but it's not something that is highly worrying. Most of the, on the bright side, most of the countries reported that the recommendations issued by the NITAG in the past 5 years have been adopted and implemented by the MOH. When the recommendations are not adopted or that the implementation is being delayed, it is often linked to funding or supply issues or lack of political will as the most common barriers. Now, for the future, the new vaccine introductions that are currently being considered by the respondents, HPV, PCV, EXA, and RSV comes first. And I think this is quite informative for us to plan for the next GNN webinars. And indeed, the next one will be on HPV. We'll follow recommendations and implementation of countries who have advised on 1 dose, and we will also discuss the supply issues. So as Kamel mentioned, there were 2 components of the study. The first one was the survey sent out to 68 countries, filled by 66 countries. And then the second part of the study was in-depth interviews with a selection of countries. So far, we've done Ghana, Albania, and Tunisia, and El Salvador. To reply to any questions, how these countries were selected was done in a very opportunistic way, because we had contact with these countries or because we were meeting them. What comes out of the interviews is really echoing what I have been showing you in terms of successes and challenges. In terms of successes and best practices, to compensate with the lack of local data, some NITAGs have used regional or shared experiences with neighboring countries or with other NITAGs from the same region, and or have involved national stakeholders to collect the data and ensure that up-to-date evidence was shared with the NITAG members. And the second aspect that I want to stress is really that the NITAGs is not only recommending on the introduction of a vaccine, but also giving programmatic advice to the MOH. So for Ghana, it was recommendation on the implementation of a surveillance systems to collect national data, because local data was missing when they were doing the evidence review process. And then in Tunisia, it was a recommendation to develop a strong media and communication campaign to address potential hesitancy. So I think this is really critical, that the work of the NITAG is not just recommending yes or no for the introduction of the vaccine and the number of doses, but it goes really beyond, and programmatic aspects should be considered as early as possible in the evidence to recommendation process. Hence the need to really include the different stakeholders, and that is again a limitation that has been flagged in the different countries interviewed. One is the limited capacity of the NITAG Secretariat, but also the evidence gaps, and finally some missing stakeholders. So in summary, there are quite a few positive findings. The first one is, as Kamel mentioned, we have had a huge response rate, and the results can be considered as representative of the mix diversity worldwide. 20% of the respondents are NITAG chairs, 47 are NITAG core members. So this ensures that the survey brings the different subject matters experts' perspectives. And then 72% of the respondents believe there is sufficient clarity on the NITAG's role and responsibilities in the local context, showing that NITAGs are now a well-established body of the health institutional environment. Most countries reported that their NITAG has a secretariat. So this is reassuring. Then we would need to go into more nuance into how many staff are dedicated to the NITAG within that secretariat, or how much time can be allocated to the work of the NITAG. But this is a different topic. And then, as I mentioned, the membership is reflective of the WHO recommendations to have a diversity of expertise. 74% of the respondents reported that their NITAG's member composition adequately meets the need of the NITAG, and thus ensures that they can really consider all the different aspects of the evidence. 70% of the responding mix reported that all recommendations issued by the NITAG in the past 5 years have been adopted and implemented by the MOH. And I think this goes also back to back with the fact that the work plan of the NITAG is really jointly developed between the NITAG chair, the Secretariat, and the MOH. Of the 56 countries, 62% are members of the GNN, which shows the added value of the network. And I really, once again, want to thank all of those who responded to the survey. In terms of challenges and issues, there were quite a few that were listed during this presentation. The first one is funding and technical capacity that has been flagged as the top challenge for the NITAGs to be able to operate efficiently. And it's not only the making sure that the meetings can be organized, but also that there is funding for the dedicated technical secretariat, and that these members and secretariat are being trained to improve capacity of collection, analysis, and synthesis of the local, regional, and global evidence. And I think in terms of the training needs, the first one is really around this evidence to recommendation process. And the second training needs flagged is on vaccinology. The second big challenge is the availability of national evidence and the difficult access to global data. Which make it difficult to have context-specific evidence to recommendation. Training was identified as a priority for NITAG members and secretariat. So this I've just mentioned before. The majority of respondents reported that their NITAG members adequately meets the need of the NITAG, but what we realized is that the competencies need to be extended to include other professional roles that were not initially considered as core for the NITAG, especially social scientists now with the growing vaccine hesitancy, and then health economists and clinical trial experts and health economists, especially in middle-income countries. Then we flagged that NITAGs have strong collaboration with the MOH, but limited collaboration with other advisory bodies beyond the MOH. And strengthening this collaboration would help ensure that the NITAG recommendations are adopted and that the NITAG can function well in the country. And then finally, incorporating the NITAG's expected work plan and recommendation into the different partners' plans for research and evidence generation would ensure that local data is being generated. And with that, I have a few questions for you that I will leave on the screen. Is the first one, do you think we have captured everything? Is there anything missing in the positive considerations or the challenges that we've listed? Have we missed anything? Then the second question is, we think that this survey was only done with the middle-income countries, and we haven't done a similar survey with low-income countries or with high-income countries, but we think the challenges faced by NITAGs in middle-income countries echo those faced by NITAGs in all income groups that are being documented in the scientific literature. So based on your experience, do you see differences in your income group or in your country? And then economic considerations seem very important for NITAGs in middle-income countries. Is this also relevant in your setting? And how do you address these aspects, including for participants coming from middle-income countries who are really interested to know how you address these aspects? And then finally, what should WHO and partners do to better support you if we are not already doing it? So I'll leave that on the screen, and I will then ask if there are any questions first, and then if there are any comments to the questions.
I may start with a question, Luis.
Yeah.
Did you find a difference between the responses in the countries that were before GAVI eligible and graduated, and now are out of GAVI?
No, there are no major. Let me just stop the sharing the PowerPoint. I'll just show you one slide that has been hidden. But no, there are no major differences between GAVI, former GAVI eligible countries. The one question that we ask, which may be of interest, is the potential challenges following a GAVI transition. And I will unhide the slide if I can. I don't seem to manage, but anyway, the question was, how has your country's transition from GAVI support impacted the NITAG's consideration of new vaccine introduction? For 30%, there was a negative change because the NITAGs had less opportunity for strengthening its functioning, and there were more funding constraints, of course. And 45% declared that there was no changes from GAVI support to former GAVI eligible country. I see one hand. I see one hand from Joachim. Yes, Joachim.
Okay, sorry, I couldn't find the unmute button. Can you hear me okay?
Yes.
Okay, so I have a question, namely, was there any question in the survey that related to the linkages of the NITAG to the local academic community? Because, I mean, there are these questions about local data, there are these questions about relevant research. And I mean, also remembering the discussions at the last Afro-Right meeting, this issue came up, and in middle-income countries, there should be an increasing also academic community and network on which a NITAG should be able to tap on. And so I was just wondering whether this is something that you have been able to survey.
So we did survey if they had formal linkages to the different advisory committees, but not to specifically to national academic institutions. We asked them also to list, yes, to list what other advisory bodies contribute to immunization policy decision-making in their country. And mostly it was professional associations, drug regulators, and academics came third. But we didn't ask the specific link between the NITAG and the academies, no.
Thanks.
Jennifer?
Yes, hi, can you hear me?
Yes.
Yes, thanks for the presentation. I wanted to know if there was any linkages that were done between this this study and the NMAT. Were there any comparisons as to, you know, when you got the answers, did you kind of look and say, oh, this aligns with what was received in the NMAT results? Thank you.
No, we didn't do that. Yes, CD?
Thanks, Luis and Kamel for this survey. Very useful for us. So my question is related to the number of years when the NITAG was established. Is there any linkage between the experience gained through years and the needs in terms of training and also secretariat support during this survey?
Kamel, do you want to respond?
Yeah, I mean, I can share a slide. I don't know if I can share slides, if I have rights to share slides.
Is it this one?
Yeah, this one, yes.
Yes.
Yeah, I just want to say, yes, CD, we looked, we asked to the participants to tell us for how many years they've been in their respective roles. And this gave us an idea of the representativeness of the responses. And indeed, most of the participants, 34% have been in role since less than 2 years, and around 30% between 2 and 5. And I would say that 25% between 5 and more than 10 years old of work in this area. We looked at some of the criteria to see if there were differences between the people. And let's say we took 5 years as a threshold, and we compared that. We compared some of the data, not all of them, to be frank, but some of them. And indeed, we saw that there were a bit of differences, like the identification of the issues were slightly different. The identification of the needs, for example, for training, were not the same. Especially for ETR. So there was some slight difference, but for the main variables, the ones that were related to the issues and challenges that the NITAG was facing, they were very similar. So no big difference on that, on those key indicators. Over.
And Christophe?
Yes, hi, and thanks. This was really interesting. I was just wondering, a bit provocative question. So since you seem to, although you haven't shown the data, but you seem to imply that there's no real difference between what MICs experience and what other income group countries might experience. Does that mean basically that for the topic of NITAGs, and I know it's probably not true for everything, that we should stop basically focusing having a specific focus on mix, and that basically this is the last time we see a survey specifically on mix, and rather look at something else. For instance, is it more the size of the country that has a role, and then, for instance, the pool of expertise that is available, and potentially other issues, language, etc. Over.
So I'm happy to start a response here, if you allow me, Louise. I would agree and disagree with you, Christophe, in the sense that if the main issues and challenges are similar to the other NITAGs, we can still see that there were like some specificities of mix in terms of supporting the Secretariat and the NITAG functioning, in terms of, let's say, funding of the activities of the NITAGs, like the meetings, but for the Secretariat, having dedicated persons. We don't have data for the other countries, but it seems that from the interviews and the data that we have, it seems a more accurate problem for those mix. However, this is not that different from the other NITAGs. One specific issue, and Louise highlighted it, is the importance of all the discussions around the financial aspects of the recommendations. NITAGs in mix, because they don't have support, I would say the countries don't have support from GAVI or from the government in a high-income country. They are struggling in terms of taking into account those questions around the funding that is available for a vaccine introduction, the cost, the sustainability, the cost effectiveness, all those questions. So I think those questions are specific to mix. I'm sure that they will expand in the future for all the countries that are low income, that will become middle income. But it's different from the others. So I would say at the end, to respond to your overall question, is that yes, I think that probably there is not an absolute need to separate the mix from the other countries in the future, in terms of strategy, in terms of support that is provided to them. We should take into account that they are a bit lagging in terms of financing of the NITAGs and the Secretariat, but we also need to see the questions around the finance as a key element for mix, but also probably for the other countries in the future. So yes and no, I would say, but maybe Louise, you have another perspective here.
No, I think I would echo what you said, and I think we have, so in terms of the support that WHO and partners, I think we are already trying to address the specific challenge of around the financial aspect. We have developed a module on how NITAG should use the health economics, and we have piloted it in 2 regions so far, and we will continue piloting it before making it widely available. That's the first thing. Then PAHO is also taking the lead in developing cost effectiveness studies to support the middle income countries. And coming back to acknowledging that the middle income NITAGs in middle income countries are a bit lagging, and going back to Jennifer, your point on the NMAT. Remember that when we compared MRO, PAHO, and AFRO NMAT results, we've seen that indeed, in terms of functionality in all the different aspects, there wasn't clear differences between MRO, AFRO, or PAHO, but there were a difference for NITAGs in middle income countries in terms of functionality. So I think we just have to be aware of this and make sure that we offer them opportunities for trainings and for support. I don't see any more hands, but I do see a comment in the chat. So I'll just read Akbar's comment, which is, I believe that most secretariats of NITAGs are unable to fully support the NITAGs in making decisions. And I think this goes to the first slides where we said yes, they have a NITAG secretariat, but mostly the NITAG secretariat is competent in organizing the meetings and in drafting the meeting minutes and disseminating them, but a bit less so on the technical aspect, which is around the collection and review and assessment of the evidence. So there is a need for NITAGs and their secretariat to have the ability to outsource their questions. Additionally, they should have the capacity to prepare requests for proposal and have sufficient budget to fund systematic reviews or prepare answers to their questions, such as economic evaluation and so on. So yes, this is well noted. Any other? I'm gonna put back one last time the slides with my questions and encourage if there are any other points you would like to. If you're too shy, you can put it in the chat. So I'll just repeat my question. Do you think we have captured everything in our survey and study? Are you also in agreement with the fact that the challenges faced by NITAGs in middle-income countries are also faced by NITAGs in high-income or in low-income countries? How do you address the economic aspects in your NITAG? And then what should WHO and partners do to better support you? So feel free to reflect. The slides will be shared. You can put in the chat if you have any ideas. Otherwise, you can send us email post webinar. I'll stop here. I also see that there are questions from Celia Martinez in the Q&A. So Mario, in case I misunderstand, you can help. Algunos de los NITAG llevan adelante investigaciones para tomar decisiones. Kamel, do you speak Spanish fluently?
Lo entiendo más que lo hablo, pero let me leer en cuanto a So yeah.
No, go ahead.
Okay, now I was going to say, indeed, the NITAGs in the middle-income countries expressed the need for support regarding the studies that needs to be implemented in the country to get local data, because they expressed the lack of local data as a main issue when it comes to make recommendations. And even if several countries reported the use of regional data or the use of data from neighboring countries, most of them said that still the credibility of the recommendation may be challenged when the data are not based on national studies. So that's something that they considered as important. And they also insisted that they're also struggling whenever they make a recommendation regarding the data that they would need to make a recommendation in the future. They are struggling to get some of the partners to support those studies, either financially or even conducting studies themselves. They are saying that it's a bit difficult to get that in place. And they also said that it should be there should be a way of sharing those recommendations for more studies with the other partners in a formal way, so those partners commit to support what countries really need, rather than doing studies that are not related immediately to the need for the NITAG. So that's to respond to the first question.
Then in terms of the type of funding that NITAG receive, I think the most important is that you have funding for a dedicated staff within the NITAG secretariat, and not just that the secretariat functions come in addition to so many other work obligations, because otherwise that would be the reason why the NITAG secretariat is unable to perform the collection and the evidence review. And then you need, of course, you need funding to organize the meeting, so to have a room, to offer some kind of compensation for the NITAG members coming for one day or for an afternoon to the city. And additionally, you can, depending on what is on the work plan, and this is why we insist that the NITAG needs to have an annual work plan, you then can flag what are the funding needs for each policy question, whether it is to conduct a systematic review or to generate other local data. Do you want to complement, Kamel?
No, I was just going to say that when we asked the question regarding the source of the funding, most of the NITAGs reported that the funding was mostly coming either from the Ministry of Health in the majority of the cases. So it was funding mostly to organize the meetings or some funding to support the secretariat. But they also, some of them also mentioned that sometimes they get support from WHO or other international organization, but mostly WHO. So those are the main source of funding for the MICs in the survey.
Yeah, I will also react to what Mauricio is saying in the chat. WHO can support vaccinology courses to the NITAG new members. So indeed, there are different vaccinology courses. One is in Afro, there is a dedicated NITAG vaccinology course happening every year, early July. This is a key opportunity for NITAG, new NITAG members to be equipped with the different vaccinology concepts. There are other regional vaccinology courses, and then there is the ADVAC course. We really encourage that NITAG members apply to ADVAC. It's a great opportunity. It's very intense. It's 2 weeks. But there is funding from WHO. There is also opportunity via ADVAC. So do consider applying, and do consider encouraging your NITAG members, if you're a NITAG chair or a secretariat, that the NITAG experts apply. Because indeed, depending on your area of expertise, you may not necessarily be able or equipped to understand all the evidence that as a NITAG members you're requested to review. And then final question from Frank. Do all NITAGs have a mandate to capture other immunization measures than vaccines? I wonder, as you asked about what new vaccine introduction NITAG consider, but are they also able to consider antivirals? And this is for the RSV. Do you want to address this, Kamel?
Yeah, typically for now, I mean, Frank, I don't know in which country you're based, but in many countries for now, I mean, there is zero discussion either regarding the RSV vaccine or the RSV monoclonal antibodies. However, we expect in the near future that some RSV vaccines will be available for middle-income countries and will be available from other countries with GAVI support. So the discussion will happen probably in the next 2 years or 3 years. I personally encourage countries to consider when they review the RSV vaccines to also consider, of course, the RSV monoclonal antibodies if they are or they will be available in those countries, because that's also another issue is the availability of those monoclonal antibodies and their price. But if you decide to consider the RSV vaccine, I really encourage you to have an exhaustive thinking around the RSV and therefore considering both the RSV vaccine and the monoclonal antibodies, because those have different objectives, they have different targets, they don't have the same use, but they are complementary one to the other. So yes, I think it's a good thing for the NITAG to consider also not just the vaccines, but in that case, the monoclonal antibodies.
And just to complement, but not regarding RSV, but we do encourage NITAGs to reflect on their mandate and on their terms of references to expand expand a bit their mandate initially, especially in low and middle income countries where the NITAGs were established around 2010 following the GVAP recommendations. The NITAGs were really seen as advisory bodies for new vaccine introduction and specifically for childhood vaccination. Now we are really taking a life course approach, so hence the need for different experts that would reflect this life course approach. But we also asked in the survey the NITAGs if they are involved in the national immunization strategy, and also if they are requested to provide recommendations around optimization. And most of the respondents said that they are providing recommendations on optimization. So do ensure that regularly you check the terms of reference of your NITAG and you consider revising the terms of references. I will just reply to the last question, and then we need to move on to the second part of this webinar. The question is on vaccinology courses, that where can we access the information on the different vaccinology courses that we mentioned. So Kamel will share with you the link of the IGVAT, International Collaboration of Vaccinology Courses. So there is a website where you can find all the different vaccinology courses that exist in the world, how long it takes and what's the program and so on. And then early July, quite soon, there will be the application for ADVAC that will start. And if you're registered in the GNN monthly update, it is always included that this is starting, that the deadline is this. And so I do make sure that that the vaccinology courses are being flagged in the GNN monthly update. Thank you. And I will now hand over to Philippe.
Yes, good morning, good afternoon, good evening. I'm Philippe Lambert, the Executive Secretary of IBB Standing Immunization and Vaccines-Related Implementation Research Advisory Committee. And I'm pleased to share with you some of the work we are doing to support you in your role as most relevant sources of evidence and advice to immunization decision in countries. Julie, could you share the slides, please? And move to the next one. So the work we are talking about today relates to infectious disease modeling. And infectious disease modeling can be useful to complement information decisions making on public health interventions, particularly during COVID-19 modeling. It helped assessing disease transmission patterns and estimating the impact of vaccination efforts. Today, all three levels of WHO modeling is being used to inform, at all three levels, modeling is being used to inform responses to public health questions, be it at national level, for example, to estimate the impact of SIAs in Somalia, or at regional levels where a region is planning efforts to estimate the costs of not investing in vaccine interventions, or at global levels to understand the impact that introduction of malaria vaccines would have across the world. Next slide. Despite modeling playing such a vital role, its use remains limited, in particular in low resource settings. And this is likely the case as applying and interpreting modeling requires tools and capacities that end users currently do not have in total. Finally, while modeling has become an essential tool to support evidence-based decision-making in areas of lacking data, the fact that modeling evidence is based on estimates requires careful interpretation and consideration within the whole ecosystem of evidence available. So to overcome these barriers and maximize the use of modeling evidence, countries require global normative and technical support. Next slide. And this is where WHO comes in, or rather its independent standing advisory body, IVRAC. Next slide. The IVRAC is IBB's custodian of robust evidence informing both SAGE and PDVAC advisory bodies on its qualities. And one of the key areas of work of this group is the review of modeling best practices and how modeling can best inform strategies and policy decision-making. As per advice of our senior management team in IVB, IVRAC increasingly is picking up topics of relevance at regional levels, and we plan over the next years to become a more active stakeholder in this field, working together with regions and ultimately also national levels to more closely support country decision-making through IVRAC advice. Next slide. But back to our problem with getting modeling used globally and appropriately. As Executive Secretary of IVRAC, I established a subgroup with the goal to develop a guidance and approaches to bring modelers and policymakers closer together. And my team colleague and lead on modeling, Ms. Eunice Sim, who's here in the audience, has kindly agreed to co-lead this effort. Next slide. The goal of the IVRAC subgroup we established is to facilitate the translation of impact modeling to optimally inform strategy and policy decision-making. The audience for this work range from modelers interested in how to shape modeling to respond to country and regional needs, and more importantly, the various stakeholders at country level that are involved in decision-making processes. So you as NITAG members are clearly among the main benefactors of this work, as it will hopefully support and help maximize future shaping of technical advice in areas where data are rare. Before engaging into the development of a guidance document, we mandated the University of Sydney, Professor Julie Leask, who will take over after me here, to assess what information needs end users of this guidance actually have. We are here to share with you the results of her group's work for information and feedback. And based on that, we'll continue developing the guidance document I just described. And depending on funding available, even go the next step, which is to actually operationalize the content of the guidance document through other tools or engagements with countries who are in need. And with this, let me pass on to Julie Leask from the University of Sydney, whose teams has been pivotal to generate this qualitative study. Over to you, Julie.
Thank you very much, Philip, and good evening here from Sydney, Australia, and good morning and good afternoon to you all. It's great to join you. So I will tell you about the needs analysis we did that grounded the development of this guidance. And our team is Social and Behavioural Insights in Immunisation, SABI, based at the University of Sydney. And I'd particularly like to thank my colleagues, Maria Christouagos and Ikram Abdi, who had a role in doing this study. And this study was aiming to identify how and if modelling is currently used by decision makers, the needs and challenges faced by end users in using modelled evidence, the types of guidance that would be most useful to end users. And we hoped particularly that the study would inform the content and format of the guidance directly. This is a qualitative study involving in-depth interviews with 15 envisaged end users of the guidance who were working in immunisation strategy, program and policy decisions, or modellers themselves. We aim to recruit people across all WHO regions and country classification groups. Our interviews lasted anything between 20 and 60 minutes. We had 120 pages of text to analyse. We used a framework method which has been successful for us in the past in doing similar needs analyses ahead of developing the BESD tools. This is our sample, and each line represents a person from a particular region. So as you can see, we had 2 people who were direct users or potential users of modelled evidence, such as NITAG members, in 2 African countries, and 2 who were stakeholders who make immunisation program decisions or policies, equally in African countries, and so on and so forth. You can see that there's a spread of regional offices represented here. Each line, as I said, represents an individual from a country. So we were trying to get a nice even spread there across the different roles and across the different regions and income classification groups. So the study findings. First of all, we were interested in describing the patterns we saw in the existing knowledge and use around modelling. All our participants understood it as a way to look forward and quantify outcomes. Those with less experience were often less confident in their understanding. They noted the complexity, or they spoke about statistical models. They were often passive consumers or used a very simplifying version of forecasting themselves. So you can see there's a quote here from a person in a middle-income country who said, as a word, I understand perfectly, but as a process, I'm a little confused. And that person had, ahead of the interview, looked up what modelling was to try and get the information and had struggled to do that, which is indicative of some of the challenges people might have with limited knowledge in getting around what it might actually do in terms of transmission modelling. Some knew nothing of international efforts to provide models. Those with more experience, however, tended to use modelling firsthand. They were involved in modelling and they used it in an advisory capacity. All who have used modelling did so to plan ahead, often with economic considerations in mind. So, for example, wanting to ensure the program was cost effective, to help predict procurement needs and other health economics questions. So this comment also indicates the kinds of knowledge that we saw among our participants. So they said, but for me as EPI person and person who are working on immunisation, need more experience of this, how this should be used in immunisation to increase vaccine coverage, maybe to calculate the number of vaccine needs and other tools and issues regarding immunisation. So there was a real curiosity about modelling, but sometimes very limited knowledge among some of our participants, and it did vary widely. People talked about barriers to using modelling. So as you can see, first of all, knowing what it is and what it can do, and that often related to access to models to help them see the possibilities from it, seeing its relevance to their own context, and accessing potentially relevant modelling. So this was a barrier for some people. From time to time, I thought that the thing that was missing during the presentation of modelling was where the idea came from. The data that they put into the model or formula that they calculated, they didn't give us a clear source of those kind of information. And it made me wonder if this is applicable to our situation or not. This was a common barrier because of the perceived sometimes lack of relevance to context, or wondering whether a model produced in a very, very different setting was relevant to context. And you also saw this from a participant from a small island nation in the Western Pacific region. They were really over-predicting the amount of, this is in relation to COVID, the amount of fatality that was going to happen. In fact, the number was way off. So because of those discrepancies, there was the cynical mind. So we say, don't trust the modelling. At the end of the day, more was actually guided by what the other big organisations were saying, you know, like what the CDC and WHO, rather than sticking with the model. Maybe because these people who can better assess these models can guide us through. So here what was happening was this person was seeing the importance of having a knowledge broker, somebody who could help tailor the findings of the models to the local context, or recognise when it didn't actually apply. But also what you see here is an expectation that a model is always going to be about prediction. Other barriers to using modelling included the in-country resourcing and capacity, which is what you just heard about with the mixed study as well. Very, very significant barrier for people. And conducting, assessing and communicating models. And that came up particularly for our modelers. So this person said, so the challenges really are that, first of all, input data can be incomplete and imprecise, so it creates a lot of variability. The second challenge is capacity. We really need a resource that masters both the software and the different types of models. Right now, we're on our own with health economics that seem to be from another era. In fact, we expect it in every language and we need it fast, not receiving the English version and waiting 2 years for the other language version. We have a busy schedule in these meetings, and this was NITAG meetings. And then the modeler has got 20 minutes time to prepare a very complex model. And for the meeting attendees, it's a black box and they don't understand, which is quite understandable. Within 20 minutes, you will not understand the complex model. So then you rely on that they trust you, that they trust the team who's doing the modeling in order to use it for decision making. This sense of trust came up several times. So just finally with the results, the guidance itself. People thought it would be useful to have a document, but it needed to be supplemented with more things. So people talked about training, but they wanted whatever it was to be presented in a user-friendly manner to allow for easy interpretation by program managers and staff who may not have extensive experience with modelling. And ongoing interactive training was very useful for people. But also having a community of practice, having relationship brokerings because of that trust and the sense of importance of the ability to interpret what it might mean for the local context. So having people who knew modelling, who had that technical expertise and could help with that sense making. And the guidance needs to cater to different levels of literacy. So as this NITAG chair said, this tool, it should be very smart and not difficult to use because my colleagues who are working in immunisation is very busy and very many instruments they're using to receive the full vaccination data. It really says it all. The document may be not enough because sometimes it's very difficult, the kind of interactive conversation or maybe electronic training course. When we face some kind of issue, we may need an interactive conversation to exchange ideas and discussion with the one who may have more experience than us. That would help a lot. So just to sum it up, people with more modelling experience, they in our study were all located in middle and high income settings. They use modelling often quite systematically in their decisions, and they saw models as a challenge in terms of time constraints and trust in the assumptions that go into models. Those with little or no experience wanted to understand the volume of the value of using modelling in their context, and they were genuinely curious and motivated. They were less confident in using modelling, sometimes didn't access it at all, wanted to see models that utilised locally relevant data and welcomed the notion of a guidance, but also interactive engagement, training, community of practice and trusted knowledge brokers, and all saw the need for capacity strengthening in the understanding and use of modelling. And of course, as we know, this requires resourcing. And what I wanted to do just as I finish is bring in this model of behaviour that has been very useful in our work in immunisation social science, which is the COM-B model. It says that for somebody to change their behaviour, for example, to use modelling more, they need to have capability. So they need to understand modelling. They need to have motivation. In other words, they need to want to use modelling, and that requires help for them to imagine the possibilities with modelling. And they need to have opportunity. And that is the resources, the time, the models, the professional norms, and the supports to use it. And it's not enough to just have a guidance. All of these things are important if we want to see something like this achieve its ultimate goals, which is to strengthen the quality of immunisation program and policy decisions. So I will hand back to Philip now for the next steps for WHO in terms of the guidance that we fed these findings into the development of the guidance with the working group to ensure that it meets the needs of our users. So over to you, Philip, just to finish it off.
Thanks very much. Next slide, please, if there is one. Yeah, okay. So basically, in the guidance document, we have like two perspectives. One is the modeler's perspective, and the other one is the decision maker perspective. So we try to understand or describe for the decision makers why they should use that guidance, what is kind of relevant in the guidance for them, and how should they get involved in the modeling processes that will take place, and then also how to interpret results and how modeled evidence can be implemented to inform decision making in countries in a robust and scientifically sound way. And then finally, how do I actually engage as a decision maker with modelers? Next slide. The target outputs, basically what as previously described, we have completed here the decision maker needs assessment. We'll proceed to the further development of the WHO guidance document and look forward to work together with stakeholders across global, country and regional levels to make sure to have their inputs on that guidance document and be able to translate modeling to inform evidence-informed decision-making for immunization. And finally, after finalizing the guidance document, there will be the training and ongoing support through existing mechanisms that we have here at IVB to serve our member states. Next, please. And with that, I'm coming already to the last slide. Looking at the time, I think it's a good thing to do. Here you can see the members of the subgroup. We have Dr. Sheetal Silal from South Africa, who is the chair of the IVREC, and then a broad mix from various regions that are there to support the development of this guidance document, which is ultimately being put together by a writing group on the top right. And then also here acknowledging again the great efforts from the qualitative research team led by Julie and also the regional offices and my colleague Uni Sim from the Secretariat for all the hard work that has gone into the effort so far. And we look forward to keeping you posted as the guidance document will emerge over the coming months and engage in discussions to finalize that and to bring this to the goal line so that you can one day also benefit fully or maximize your decision-making recommendations based on modeled evidence. Next slide. And with that, I thank you very much for your attention and hand it over to Louise as chair of this.
Yeah, Mario is chair, but happy to take any questions or comments. Don't see any for now.
Okay, in that case, maybe just one comment that we really look forward to active interaction with NITAG members, as ultimately you are the clients of this guidance document. We are already engaging across global, regional, and country level. But clearly, this network meeting is a great opportunity to share the existing efforts that we are doing and open up opportunities for you to engage with us on this if you are interested.
I don't know if you can hear me well. Just to congratulate you on this effort. And I have a quick question. It's sometimes, maybe usually the case that countries that can perform this type of analysis of modeling also have greater capabilities and may not need them as much as countries that don't have the capabilities and would rely more on modeling since they don't have enough data to make decisions. So I don't know. This is an open question. How if you're thinking about that, how the most needed it's going to be the one that have less capabilities.
Yes, absolutely. I mean, there's no one size fits all. I think we have to face the realities. There will always be countries where capacities will be so limited that they cannot let's say synthesize modeled evidence themselves. But this is the part where we also come in from WHO. For example, there has been some very good work done by Somalia, where we facilitated the contact between them and modelers to actually provide information on the impact that SIAs against measles had in their countries over the last years. And for them, it was a completely first-time experience, and it was really great to see how well this was picked up. And once the let's say the modes of engagement were clarified and the process was described, it worked well. It took more time. I think reading such a guidance document such as we have developed would have probably sped up the process much more. And this would be the goal, I think, for those countries, that the guidance document already puts them in the framework of thinking, and that then if they need support from regional or global level, that we from WHO are there to support our member states.
I see Mauricio as a question. Mauricio, over to you.
Hi, everybody. Thanks for your presentations. It was a nice talk around, I think, share problems that every NITAGs share around the capacity to make some recommendations, that there are a lot of gaps between all the NITAGs is very important to see that for everybody. I think there is still there is a lot of gaps. Julie talk around why sometimes it's difficult to take this modeling, and most of the time for the NITAG members is time, because we took time from our we are not full-term NITAGs members and only working in that. A lot of us have another works, and that's made sometimes difficult to put in practice a lot of this modeling. So, and the other problem is the formation, because we need to know really how this modeling works, and that always is time, because that take time all the times to make some preparation. And I think the problems, the same problems will be all the time because of that, because of we are not full-term NITAGs member. We have another works we have to work in that. There is no preparation for all the new members around vaccinology. Maybe we know something around diseases, but around vaccinology is the knowledge is very, very low. And around modeling, there is new knowledge around how to use the modeling. And this is my point of view, and I think there is still a lot of work to do to work NITAGs work better, to process a lot of things. So it's just a commentary around these talks, and thank you very much.
That's a very important point, Mauricio. I'm really glad that you're addressing that, because clearly what you describe is ultimately the rationale for thinking about how we can optimally support countries. And developing a guidance document is one step towards making it easier for NITAG members and public health in general. I think none of us can be an expert in every field that they're looking at, and some kind of time to get into the subject is needed. And this is exactly what this guidance document is trying to accelerate, so that NITAG members don't lose valuable time with researching the relevant information and getting up to speed and developing the capacity to support the synthesis and use of modeled evidence. So ultimately, the question is, how can we best, beyond a guidance document, support countries with tools or mechanisms that would make it even easier, so that even someone that works part-time is in a position to quickly pick this up and take it forward. Modeling is something that is coming. It clearly has shown its benefit, but also limitations during the COVID pandemic. But since then, it has grown beyond what has been previously a privilege to high-income countries and global level activities to an exercise that is being increasingly identified at regional and national levels to help countries respond to questions that they were previously unable to answer because they had lack of data.
If I could just add there as well, along with the challenges that you've been all talking about, there's the challenge of modelers communicating modeling clearly, and sometimes with quite complex models that can be quite a challenge. It's sometimes quite a technically complex area with jargon that is very familiar to modelers but may not be to others. So plain language communication of models, their limitations, the uncertainties, what they can and can't do, what their findings are, their assumptions, they're all skills that I think are extremely important in making modelling accessible when it's being done. And I also just wanted to add quickly that Uni has said in the comments that this guidance will address different scenarios, ranging from where countries co-develop models from scratch to where countries use existing models using data, or where countries explore transferability of existing evidence from one setting to another. And this was based on the qualitative study. So just important to add that comment from Uni. Thank you.
Yes, indeed. A very good point from Uni. And I think one of the conclusions of this meeting is that at the next meeting, when we meet on this, we'll discuss the structure and let's say the methods presented in the guidance, so that you get let's say a more three-dimensional insight into what this is going to bring and how it should best be used. So really looking forward to engaging with you all on that again when the point has come to review that guidance document.
So I see no more questions. I saw some comments, valuable comments on the chat to also encourage NITAG members to use the vaccinology courses as opportunity to be up to speed on modeling. And then Nasi shared a great resource that they've developed around health economics interpretation used when they're using modeling and health economics in their recommendation. With that, I think we can bring this webinar to an end. The recording will be shared along with the slides. And the next GNN webinar will likely be in end of August, and it will be on HPV. So thank you, everyone, and have a good summer.
Thank you.
Thank you. Bye, Luis.
Great day. Bye-bye.